want y'all to look at this slide here while I talk about it, but as he intimated, I am an echocardiographer, but I'm an old echocardiographer. And I'm constantly told that I should call that seasoned, because that's a much better term. That even an old guy like me can learn new stuff, right? So this slide is AI generated. It's the only one from me today, and I think it was actually pretty well done. I really like the way that the points, the rapid cardiac assessment, diagnosis and intervention, enhanced monitoring and outcome, all the things that we excel at with echocardiograms. What's the really obvious mistake with this slide? Anybody see it? How many echo pictures do you see up there? None. So I don't really know what the AI was coming up with. I think I did a little better job on it here, because this makes a little bit more sense now. But at least I tried it. The PowerPoint kept hitting at me and saying, hey, you got to try this. I was like, okay. So we'll give that a try. So I think it's kind of important for me to describe how I got here giving a presentation on this subject, as I'm going to try and do it in 2 minutes or less. I know we're not supposed to talk about ourselves, but I think it's really important to this because it gives it context. So I finished echo school. Actually, Robert, I'm not as old as you said. I finished echo school in mid of 1981, okay? So not 1980, but I ended up working for almost a year in Phoenix initially, and it happened because no one in Tucson had bought a two-dimensional system yet. That's pretty wild. They were all using M-mode still, and I'd been trained in 2D. So I had to go work there for about a year, got back to Tucson. They bought a 2D system finally, and then I returned home where I worked in every possible situation that was available at that time. I stayed in Tucson for 14 years. I worked for a large Catholic hospital, and I was doing lots of freelance work. And I heard later, actually, from some folks that they called me an echo whore. That was a little tough at first, right? But then I realized they were right. I would go anywhere and do an echo for $50. So maybe they were right. So after that 14 years, my wife and I, we hit the road as travelers for the next 14 years. And yes, we lived in an RV. We lived all over the country. We managed to hit 48 states. So it was a pretty neat ride. I worked for a lot of different travel companies, and my wife had her own travel company. Some of these name tags you'll actually see belong to around here. I think we've got one from Spartanburg Regional and a couple others ones here. But basically, we ended up in 2009 up in Baltimore at UMC Shock Trauma. And the SICU director up there knew that I was a pretty serious echo geek, and he introduced me to one of the sales guys there on my last day. And the SICU guy thought that this sales guy had a neat product, and they might use it in their SICU. So they're telling me about it, and I'm like, okay, it sounds kind of interesting, but doesn't really sound that interesting, and we exchanged contact info, and that's the last thing I think about it. His boss calls me the next day, pays me to fly to Florida to a trade show, and I end up being hired as their first, and for a while, their only clinical sales specialist. That was the beginning of an amazing transformation for me with this new startup company out of New York. The product was a miniature TEE probe. It was disposable, and it could stay in the patient for up to 72 hours and monitor the patient's hemodynamics. And they're showing me this. The inventor, the owner, everybody's right there. They're showing me this thing, and they are really excited about it. They're thinking, this is awesome. But in my head, I'm like, why? Well, to monitor the patient's hemodynamics in the ICU. And I'm still like, why? I'm still surprised they hired me, actually. I wasn't getting it. I just didn't get it. It turned my whole world literally upside down. First time I'm at the bedside of a septic patient. Their kidneys are going down, their brain's going down, their guts are going down, their limbs are going down. It's a mess. The ICU intensivist has told us that he's following the surviving sepsis protocol. But it's clearly not working. And this 50-year-old lady, she's going to die. She's on maximum therapy per the protocol. She's very unstable hemodynamics. There's that word again, that hemodynamics word. We show up, we drop the probe in, and she has a hyperdynamic LV. It's very underfilled, and it took us 5 minutes to get the information. It was the exact opposite of what the intensivist thought was happening with this patient. She's puffy, there's sure more fluid would be very bad for her. So we do that echo, and we find that. And they're like, okay, we're going the wrong direction. So they bolus a liter of fluid immediately, start rapidly weaning our pressors. And it was a long night with that patient. They did the probe multiple times to look and see what we were doing because it was all new to them. She received a total of 3 liters of fluid, and she was off almost all pressors by morning. Her skin looked better, had better perfusion, her mean arterial pressure was back to normal. The intensivist and the protocol had sent them in the wrong direction. This was amazing stuff. We had actually saved her life with ultrasound. We provided the intensivist with the needed and correct information at the right time and in the right place. I think that's a pretty cool story. Sounds like pretty isolated though, right? Probably hardly ever happened. In 8 years I was on the road with this company. I saw this happen hundreds of times in dozens of ICUs throughout the country. We tried to get back into that ICU up in Maryland. And I talked to that SICU director, and he's like, no, we're not interested. I'm like, how can you not be interested? This thing is incredible. They actually began staffing an echo tech in the ICU. 10-hour shift, on call would cover it afterwards, so that they always had echo with them every single time they had a question about a patient's hemodynamics. So that started another question for me. Let's see what you guys can come up with here. So what is the purpose of the ICU? I would imagine it's pretty obvious, or it seems pretty obvious to everybody. So that's where they keep the really sick people, right? And where echoes are harder to do, and you have to move lots of stuff to get in there, and the nurses want you to hurry up, and blah, 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 right? I mean, that's just the normal ICU environment, right? I didn't get it until that patient in 2010. Up to that point, I'd been doing everything with a strict cardiac focus, just like everybody else, cardiac diagnosis, cardiac disease. It's just what we do. I had done thousands of echoes in the ICU, lots of them in the non-cardiac ICUs, but one question I never asked was, what is the purpose of the ICU? And I still didn't know the answer. And actually, I'm pretty sure I didn't even know the question. ICU providers provide high acuity care for acutely ill and injured patients. That's what they do. So now you know, and maybe you already knew all this, but I don't want you to have to work as long as I did before I finally figured it out, because it was pretty darn important, but the more I thought about it. So let me ask it a different way here, though. So what's the primary job of the ICU? Still what I just said, right? Take care of sick people. This is how they do it, though. They provide adequate perfusion to all those systems, and it doesn't matter whether the therapy is medical or surgical or a combination of both. But whatever, if it doesn't work, they die. It does not. There is not a lot of room for error here. So I had an intensivist tell me something that was really, really recent, or really recent, good, really important to me. He says, he developed an idea of what was going on with that patient and then decide what therapy is needed to manage the hemodynamics, right? And then they use the technology to either confirm or deny what's really happening, and it gives them a clearer view of what's going on. Well, that sounds like just what I described in that very first SICU echo that I did. They had no idea what was going on. They used the technology to help them sort it out and try and save that patient's life. Now, I don't know if you guys have ever been in a room that looks like this. What do you think? There's a patient in there somewhere, but it's hard to pick him out. But the efforts of the ICU to maintain perfusion can get pretty intense. And maybe that's why they call it intensive care. I have no idea. It's possible, I guess. But this is an ICU room at Vanderbilt, and it demonstrates a lot of what I have seen as intensive care. But I would call it the extreme end of intensive care. What did we decide? The laser work over here? Oh, it does on this one. Okay, so the vent's pretty easy, right? All the ICU rooms have that vent. But what's this big thing right here? It's a big tube of blood. It's ECMO. So it's either VV or VA ECMO going on that guy. This controller right here is controlling the LVAD on that patient. And this machine right here is actually the company I was working for that we were using ultrasound to monitor this patient's hemodynamics, adjust the LVAD, adjust the ECMO, and try and keep him alive till the rest of it got better. If we can't keep your brain and your kidneys alive, we're in big trouble. So it doesn't have to be this extreme or intense to be ICU care, but it's all about managing the hemodynamics. And this is the world that I lived in for 8 years. And this is where I met my ex-friend, Robert Smith, and we were both absolutely blown away by the impact that using echo or ultrasound really in the ICU could have on patient care and outcome. I confirmed this with him when I met him again yesterday. I said, it changes forever the way you do echo in the ICU, because you now know what it is that the doctors are looking for. You now know a little bit better of why they're doing what they're doing. We can give them the same answers that we did with that fancy machine right there, but we need to understand the environment better, and we need to understand that we can have the biggest impact because it is still all about hemodynamics. I was doing an SDMS CME activity one day, and it talked about hemodynamics. And it says the flow of blood through the cardiovascular system. So the ICU is all about managing the flow of blood. Okay, that makes sense. Did they teach you anything about that in echo school? Does that sound familiar? Or do they didn't teach us anything about that on our clinicals or our board prep, because it's not those types of questions. It's doctor stuff. So how do the doctors manage hemodynamics, right? Now, I'm not talking about the complicated mechanical circulatory support person on that other page. I'm talking about the regular guy or gal that's in the ICU and they're on a vent. How do the doctors manage the patient's hemodynamics? It's got to be a big list of options, right? I mean, doctors are really smart. They must have a lot of different things that they can do to try and manage that patient's hemodynamic. Actually, they do it by administering 3 different therapies: fluids, vasopressors, and inotropes. That's the main tools that they have, is manipulating those so that they will do and maintain organ perfusion. So hemodynamics are basically the foundation of critical care. And back to a little basic physiology here. Dave is left already for the day that gave that great hemodynamics presentation, but he touched on a lot of the things that I had in my program, and I'm going to leave him alone because he did such a great job of explaining how that all works. But it all starts off with knowing if there's any abnormalities in the anatomy or in the baseline function issues. Does the patient have any of that? Now, if they're in the ICU because they had a gallbladder surgery, most likely they already know kind of what was going in. But if somebody is in the trauma unit, the trauma docs, they have no idea what's going on. They need us to help them out. So now the fun stuff from you and I, right? The echo answers a lot of those important SICU questions, or ICU questions, I guess. It can confirm basic anatomy. It can reveal what the function and filling status is at that point in time. And the echo can determine if there's adequate preload. But wait, that's not a line on our echo report either, is it? Anybody ever write down preload on your echo report? Raise your hands. Nope, no hands. Big surprise. That's not something we measure, right? It's there, it's part of the program, but it is not something that we think about when we are doing echoes and giving echo reports. Now, we've been shown a little bit already that it's vitally important to have adequate preload and filling, but it's not something the cardiologists put in their report. The echo in its report is a moment in time, and that report is often well behind the real-time hemodynamics of that patient. Is there adequate function, and is there adequate contractility? Now, let's take a look at what the monitors are telling us. You walk in that ICU, you see the monitor up there, you've got blood pressure, you've got mean arterial pressure, you've got cardiac output, SVR, lots of different things that they put up there, and it's basically all talking about pressure, flow, and resistance. Now, you need to look at the patient. How does that patient look? How many times have you walked into ICU and the patient is all puffy like that one I described, or they're super cold, or they're super hot? They could be squishy. It's kind of an icky thought, but they're kind of squishy. They could be having a fever. They have a cold. Who knows? But you've seen it in all those patients that you've gone up to the ICU to do. And what we're doing is trying to facilitate organ function. That's what this is all about. We have to keep the organs perfused to allow the body to recover from whatever disease or surgery or injury that it has suffered. And how do the providers do their best to make this a reality? By managing hemodynamics. Now, your monitors may look a little bit different than this, but basically they're going to display a lot of the same types of things there, okay? So blood pressure can be up here. Mean arterial pressure is just basically showing us the mean value there, the pressure that is within the system to help maintain those hemodynamics. The other number here is that SVR. Now, that's not one that we talk about a lot in the echo world anyway. It's systemic vascular resistance, but it's something that we need to at least understand. It refers to the resistance the blood encounters when it's flowing through the systemic circulation. And it can be due to constriction or dilation of the arterioles. It's a measure of how much resistance the heart needs to overcome to pump blood through the body. So I didn't know this, and so when I started out with this, and so I had to learn this particular thing, but a normal range of SVR is between 900 and 1440, and that's what you'll see up there on the monitor. If they have a low number, that means you may be seeing sepsis, anaphylaxis, spinal shock, adrenal insufficiency, hyperthermia, or vasodilator use, because it affects that number. Now, if you see that number is high, above 1440, that means they could be hypovolemic, like that patient that I showed you earlier, cardiogenic shock, hypothermia, or it could be due to the vasopressor use as well. Either way, this information without us is incomplete because it doesn't tell us everything that's going on with that patient's hemodynamics. We are the key to the whole concept because when you use that information with echo, we get complete hemodynamic information. Filling and function determine the blood pressure. It's displayed as MAP, like I said. Most ICU monitors report those basic calculations, and when we do an echo and we're watching the LV function, we're watching the process that creates that blood pressure. So this is a term that is a lot more common in nursing. Now, a lot of you guys are newer students and stuff. Do they use clinical critical thinking in the echo world? Do we talk about it much? Anybody? Okay, no. So basically, I want you to start thinking about that. So you head to the ICU, where I want you to stop for a second. I want you to perform this echo or kind of frame this echo with the real clinical question in mind. How many times have you gone to the ICU and you have an order that says LV function or sepsis? Or heads nodding over here, right? Because that's what you get. What we're trying to find out is what is the real clinical question? Why do they really want us there? I want you to ask questions when possible. I want you to use those answers to mentally walk through your checklist or your protocol and identify where you can adjust it and utilize it to answer the real clinical question. These are the decisions that you make in real time, and this is not just about what you saw. It's about what it means and how it can affect the outcomes. If you're in the field very long, somebody says you're just a picture taker. But we don't just take pictures. We make clinical decisions in real time, every single day, critical decisions. I read once in an SDMS article, a different one obviously, but it says behind every difficult diagnosis, there is a sonographer who provided the first clear image. And they're talking mainly about general sonography and that kind of stuff. But I would offer that in the ICU, we have the potential to be behind any successful ICU recovery and resuscitation. There's likely an echocardiographer that provided the correct and timely hemodynamic information to take care of that patient. An echo in the ICU is finding out basically why are you there. I want you to really understand what the provider needs to know. It's about helping the physician and the provider know how best to treat you, or actually their patient at this time. Someone shared a really good way of describing this with me, and I've stolen it because I think it really is impactful. I want you to listen carefully to this. I would call this deliberate scanning. I don't know if you've ever heard that term before, but it resonated with me. I want you to practice deliberate scanning. I want you to be a deliberate scanner. Do not be a robot. You know what the opposite of deliberate scanning is? Thoughtless scanning. And that is a failure on our part. The ICU is an incredible training and learning environment. It is where thinking with the probe in our hand is critical. I recently learned of a facility that gets their newer sonographers up to ICU pretty quick. And I'm like, that's pretty gutsy, because I mean, they're going to be kind of intimidated. And they said what they do it though is they do it with a seasoned sonographer with them. They said senior sonographer, I just correlated seasoned. But to mentor them, to show them how to act in that environment and to work within it and to practice deliberate scanning. So now the title of my talk here, Echo in the ICU. Well, if it comes up, there we go. All our ICU is the same. When you go to the SICU, is that same as going to the CT ICU? No, of course not, right? But we go everywhere, right? There's nowhere that they don't need us to be there. So I asked earlier what the purpose of the ICU was. So now I want you to think or ask yourselves, what is the purpose of Echo in the ICU? Any of the ICUs? And the simple answer is we are a monitoring device or a tool. Now, what one thing will be very different for us in the ICU? We often get a lot of our information from our patients, from talking to them, as multiple people have described, as you get answers from them. But you know what? Our patients are all intubated. There's no one to talk to. How are we going to find out what's going on with that patient? Now, what will not be different in the ICU? You're going to have good pictures. You want good images, right? We want accurate measurements. And of course, we're going to use lots of imaging solution, right? Is that what everybody does? I hear of most technicians going up with a pocket full of imaging solution to go up to the ICU. I think that's a great idea because it's going to help them to answer these questions, okay? But I will tell you something, and it may come as quite a shock to some in the audience here. There was a time when there was no imaging solution. Old people like me, Robert remembers that. There was no imaging solution. Well, but now we have a generation or more that have never known a time without imaging solution. So utilize those tools. And I kind of drew a little parallel. It's kind of like Generation Z that's never known a world without the internet. It's kind of the same thing here, but what do we call? I came up with some ideas. We call you Generation D for Definity, or Generation O for Optison. What do we need to do? So I'm open to some input from that later on, okay, because I'd be curious to see what we should do. But either way, with these tools and our skills, we can go into all the ICUs and directly impact the care there. Now, each unit is different, okay? The patients in each unit are different. The docs and the caregivers in each unit are very different. Now, CICU is usually the easiest one for us. A lot of times it's people we work with every day, where the docs are very approachable, the CT surgeons, that kind of stuff. But, you know, you get down into the SICU, the trauma, that kind of stuff, those are usually surgical folks. If you get down into the into the MICU, then you may be looking with more of the pulmonary docs, and certainly if you're in the NICU, you're working with more of the neurology guys. So ICU is a dynamic environment. You have to pay attention, and you have to ask questions. The real reason for that echo that you're there to perform is probably not listed on the order. Have you been in the unit doing echo when they come in to do rounds? Have you ever taken advantage of that? Use that amazing opportunity to ask questions and to learn. But what should you be asking? How about something like, what do you think's happening with this patient? That would be really a useful thing to know, just to say, hey, what's going on with your patient? Because they will have done, like that slide I showed you, they had what the intensivist thing can do. They have done that. I have never had an intensivist say he looks at it or she ever looks at it any other way. They're always trying to put together what's going on. Now, they may well ask you some questions as well. Most common one, what's the EF, right? How many times a day do we get asked that question? Lots of them. But it's still helpful for them to understand exactly what's going on there. It's a dynamic environment, and I want you to pay attention and ask questions and learn every chance you get. So you're right there in the unit. You are the eyes and the ears of your cardiologist. Whoever's going to read that echo, you are their eyes and ears. If you don't show them something or tell them something, they're not going to know it when they look at that echo. They need to know the context of the echo. Why does it look the way that it does? So our responsibility is actually much more than imaging. It's about recognizing what information matters and knowing why it matters. So I want to share with you guys a few examples of what we need to be trying to find out when we're getting set up in the ICU and why. So first question, is the patient being treated with inotropes? Well, echo folks, most of you we're familiar with dobutamine, right? That's an inotrope. It makes it beat harder. That's fine. So that's probably the easiest one for us because we're familiar with the effects of those drugs and that kind of stuff. But the answers can have a big effect on that echo. Do you think it's important to learn that they're on inotropes? Should you maybe put something on the screen so that the reader knows that this is essentially an enhanced LV? I think that makes sense. Maybe the patient had a baseline echo, EF of 40%, and now all of a sudden it's 60 while they're in the ICU. The doc's like going, what in the world happened with this patient's EF? So it's probably not part of any protocol or process that you've ever used before, but it's actually patient care, and it is directly impacting someone's life and treatment. Now, I'm not trying anyways to be overly dramatic, but I think you get the idea. These are things that we need to be thinking about in a few what-if scenarios. Might be, what if the heart rate, is 40? How's that going to affect function and filling? What if it's 125? What if the mean arterial pressure is low? What if it's high? All these scenarios, they represent hemodynamic changes. These are all the things that can affect the heart with those, when you see patients with these things, they will very often have inotropes on board to help with those situations. And that's what you learn when you're talking to the nurse or to the other caregivers. This does not have quite the effect, direct visual impact that inotropes have, but it's still really important to know that they are on vasopressors, or, like that first patient I showed, multiple high-dose vasopressors, because the reader needs to know that at that moment in time, that is why the echo looks the way it is. The echo was performed while they had that therapy. So, if we see an underfilled and hyperdynamic LV chamber like I showed you, they may be going in the wrong direction. That's pretty important. So take a look at the monitors and treatment at the moment and note that on the screen. Now, you may be showing up as they're weaning the pressors as well. That's important to know, and maybe they're doing some fluid resuscitation. If you're looking at that empty LV and it has a 90% EF right now, it might be worth coming back and seeing that patient in 4 hours and seeing what their real ejection fraction looks like once they have been adequately resuscitated and weaned off of the therapies. Now, IV fluids, that's more of a question, are they doing like maintenance fluids? If you see a bunch of bags hanging, are they actually running? Or if they're in the middle of a fluid resuscitation, those types of things will have an effect on your RV, your LV, IVC size. It's going to look at your function. Is the LV function getting good, adequate preload or not? You can see the labels, you can see what's running, that kind of stuff. So if you can, though, enlist the help of the nurse or whoever is in that room to help you out. Now, what if you find out, because a lot of times they'll tell you that the patient is positive fluid-wise. So what if they're 4 liters positive? That means they put in 4 more liters of fluid than what has come back out of that patient. That could happen during like a burn protocol or something like that. And so what if you find on that situation, the RV is blown up like a balloon, like that picture that was up here earlier? That is important to be able to notice that and be able to tell them what's going on right then. Are they in sinus rhythm? Are they in fib? What is going on with that patient? I know, he looks like me. I like making little informational videos, okay? And this was guy, his name is Phil in my program, but I thought he looked just about right to be in the ICU there. But so let's just say you're walking into the ICU, right? The patient's already turned on the left-hand side. There's plenty of room for the machine. Good ergonomics are guaranteed. Lots of room, and don't forget, he's not me, obviously. He's got perfect pictures. But the echo is ordered by the trauma surgeon, and it's ordered for, of course, LV function, and to rule out pericardial effusion because the guy has a gunshot wound. He's back from the OR. But before we ever start imaging, we want to look at that mean arterial pressure, at the SVR, start the critical clinical thinking. Ask those questions. Fluids going in, going out, exactly what is happening with this guy. And as you find out he is maxed out on pressors and that they're having a hard time controlling his hemodynamics. Shocker of shockers. 90% EF, but an extremely underfilled heart. He's in hypovolemic shock. His body is compensating. I've heard it described actually as a fight or flight response that his body is undergoing right now. But he was probably just under-resuscitated in the OR or as he came back up post-op. And they just got out of the balance. So what do we do here? We add fluids, we reduce pressors, and it gets him back in a hemodynamically stable condition. So now, while this scenario is not common in the cardiac world, it is much more common in the MICU and SICU world. You might be all by yourself. You could be in the room with the nurse or the residents or the attendings or who knows here. And I don't know if you guys are running into this very much, but our ICUs are using point-of-care ultrasound quite a bit as well, just to take a quick look. Or even there's some situations where I'm seeing called critical care echo. That's a little bit different technology, but they're up there looking to see what's going on. And often they call us up to kind of confirm what's going on and see what's happening. It's amazing when you see a patient like that gunshot wound that I was looking at earlier, and that pressure comes up, and they get stable, and they get them off all those meds. It's an amazing thing. It's an amazing thing to be part of that care team. Now, you guys have probably seen this if you've been looking at any SDMS stuff, but I just thought, and I don't know who Francesca is, though I definitely like how they think. Being that detective is really what we need to be able to do. When I come across an answer like this, it makes me happy. But I do take a pause and answer that question in my own mind as well. I would invite you to do that, even if it's right now. Take a pause, take a deep breath, and think about the incredible opportunity that you have as a sonographer. And doing what I know is the best part of sonography, which is echocardiograms. I'm sorry, I'm biased, but I do. I feel that is where we can make the biggest impact. So this is this critical care echocardiography. I don't know if you guys had ever heard of or seen this, but it's actually called consultative cardiac echo. And I don't think the Philips people are anymore, but it is a Philips software program, and it's actually on the systems that allows you to loop in the cardiologist, the intensivist, and the echo technician all at the same time to watch the echo in real time. The potential to impact patient care is amazing, and I know this is not going to work in all situations, but I just thought, they can talk, they can text, they can screen share, and video stream right from the echo system. I thought this was one of the coolest ideas I had ever seen, because it gets rid of what I call the clinical and time disassociation, where we have time between the answers are found out by us and by the doctors, but the ones doing the treatment don't have that information. So no matter what the scenario is, whether it's a COVID patient, a septic patient, a burn, a trauma, an LVAD, a clip, a TAVR, a Watchman, a PFO closure, pediatrics, it doesn't matter. It's all about the hemodynamics. The ventricle needs adequate pressure, it needs adequate volume, and it needs adequate preload. And that's how it works. That's how it works. That's the simple part of hemodynamics. Well, I'll conclude with what I have labeled as my selfish goals. They're selfish because you may be doing an echo on me someday. You may have to do an echo on my wife, my dad, my mom, my brother, my son. Who knows? I want you to know why you are there. I want you to know what your cardiologist needs to know from you. I want you to perform deliberate echocardiograms. The rare and exotic stuff that we run across is exciting. That was not good. Okay, well, final one, so it doesn't matter. It's exciting, but the mundane is what really needs to be done well. There's always more to learn. There's always room to learn. I want you to look for opportunities to learn and to share what you've learned. I want you to take good care of my family and yours. I'm grateful for this opportunity. I'm super grateful to Robert for finally helping this to happen. We've literally talked about this for 4 years, and it has been an awesome opportunity to be here with you. I'm grateful for those of you that I've gotten to meet already, and to meet many more of you. And I just want you to enjoy your job. Enjoy the incredible opportunity that you have. Take advantage of it. You will get older. It's frustrating, I know, but it's true. I want to thank you guys. You have a good day.